So guys, I'm just going to do a summary of the lesson we did on reading ECGs. The first thing I want to tell you, this approach is something that I developed, something I have been using for a while, and it's basically a discipline so that I don't miss anything. Okay, I have 3 rules. The first is the rate. I always check the rate. Just remember these 3 rules: rate, rhythm, and shape. Okay, first, the rate. You check the rhythm strip to see if it is beating faster than normal or if it is beating slower than normal. I'll teach you how to do those. I just want to go through an overview. Next, we have the rhythm. The one thing you need to check there is you check if it's a sinus rhythm or not. What does that mean? Is the P wave present or not? Okay? And finally, the shape. What that means is I follow the PQRST wave. I follow the wave to see if there's any abnormality. Okay? We will come back to this image. First, I need to tell you, this is going to be a summary. The actual class was done some time ago. This will be a summary on how to read ECGs. And the first thing you need to know is how to identify a normal ECG. This is something most people don't know to do. And what happens then? They overanalyze. Okay? They overanalyze ECGs and they will try to find something wrong somewhere. Okay? So how do you know if it's a normal ECG? First, the rate. Rate. Look at this. I will teach you. There's around 1, 2, 3, 4. 4 big boxes. And that corresponds to a rate. The way I remember it is, if it is just 1 box gap, the rate is 300. If it is just 2 boxes, the rate is 150. 3 boxes, rate is, let me write the boxes, 1, 2, 3. The rate is 100 when it's 3 boxes, 75 when it's 4 boxes, 60 when it's 5 boxes, and beyond that, it's going to be bradycardia. Okay, so this range is a normal heart rate. Okay, so in this there's 4 boxes. There's roughly 4 boxes between the PQ, R, S, T. This is the normal wave. Between the 2 R waves, you have 4 boxes. That gives us a rate of around 75. Okay, that's normal. Next, rhythm. You check to see if there is a sinus wave. What does that mean? You check to see if there is a P wave. Okay, and finally, the shape. So you follow the wave P, Q, R, S, T. You can see P, Q, R, S, T. You can see that it's all there. All 3 rules satisfy a normal ECG. Okay, so this is the summary of all that. An inverted T wave in lead VR is normal. Okay, and a normal P to R. What is P to R? P, Q, R, S, T. P to R interval is about 3 to 5 small squares. Why is this important? Because this gap is going to tell us a lot of things. It will tell us a condition called a heart block. Okay, and the QRS complex is usually around 3 small squares. Okay, next I will tell you about the lead placement so that you know how to locate which area of the heart is affected. Okay, if there is a defect in the leads 2, 3, AVF, that means the problem is in the inferior leads. In the inferior region of the heart, you have the problem. If it is a problem in 1, AVL, V5, and V6, it's a lateral lead problem. Okay, I will explain this a bit more. Before that, V1, V2 are anterior leads. Okay, you can see I have placed them anteriorly over here. You can pause the video and draw this diagram. Finally, V3 and V4 are septal. The way you remember these is like this. 2, 3 AVF, you need to know, is for the inferior section of the heart. We'll take the precordial, that means the leads related to the heart, the precordial leads. So the way you keep it is V1, V2, V3, V4, V5, V6. Okay? So you can see V1, 2, 3, 4, 5 and 6. So what does V1 and V2 tell you about? The right side of the heart. Okay, remember that. V3, V4, the septum, and V5, V6 tells you about the left side of the heart. Okay, basic anatomy just related to that. This image, I will come back to that next. So these gaps are for the parts that Prashant did in his lectures. You can fill that in. Sinus bradycardia. What does brady mean? You will hear this word in a lot of places, mostly related to the heart, but even for diseases such as malaria, you get bradyzoids. It basically means slow. So bradyzoids are slow dividing malaria parasites. In this, it means slow heart rate. Okay? Why do you add the word sinus here? This means it is the P wave is going to be present. Okay? Now, let me take the measurement. You need to check the R to R wave. Okay? You can count the boxes 1, 2, 3, 4, 5, 6, 7. And as I told you before, 6, 7. 7 will be somewhere here. It is definitely bradycardia. So the first rule is rate. We are learning to read the rate now. First, rate. We look at the rhythm strip actually. This is the easiest strip to read. The R to R gap is 7 boxes. And that gives a heart rate less than 60. That is a bradycardia. You get it in these conditions: athletes, hypothyroidism, hypothermia, obstructive jaundice, and understimulation of the sinoatrial node. Okay? Next, we have sinus tachycardia. And what's important here is, again, it's sinus wave. You get a P wave. Sometimes it is found hidden inside the next T wave. Okay, that gives you a camel hump appearance. Okay, what you need to check for here is the gap. Always use lead 2 because that is the rhythm strip. It's a long strip, you can see it's long. So you can actually judge the rhythm to see if there's any alterations in the rhythm. Does it suddenly become slow or fast? So you can see the gap is 2 boxes. So the rate is going to be 150 beats per minute. Okay, 300, 150, 100, 75, 60. Just remember it like that. And remember, don't go to count the small boxes, multiply it by things and try to find the exact rate. That's useless, because in an ECG they will tell you that rate, but you don't need to look at all those. You just need to know by the big boxes what the rate is. Okay, and I need to tell you that these links I have given below, you can follow those to learn more about each ECG. That I gave credits for the ECGs that I took from these people. Okay, so this is a sinus tachycardia. Next, we have a condition. This is one long ECG. It goes this way, it's one long ECG. You will see there's tachycardia, 2 boxes, and there's bradycardia. See, look at this gap. So this is gradually becoming faster as you go this way, and you have tachycardia. So this is called sinus tachybrady syndrome. Another word is sick sinus syndrome. Okay, and this is not related to inspiration or expiration. Just remember that fact. Okay. Next, we have paroxysmal supraventricular tachycardia. This is the same as sinus ventricular tachycardia, supraventricular tachycardia. This is a condition in which the heart suddenly increases for about 3 to 5 beats. around 3 beats, you get a sudden heart rate. So usually this happens after hear exciting news or after drinking coffee. And these patients have sudden onset palpitations, dizziness and syncope. Okay. Next, we go to rule 2. Rule 2 is about rhythm. Rhythm, you check for the P wave. Can you see a distinct P wave here? Can look carefully and tell. Look at wave 2. So I need you to remember this. Wave 2 is a vector addition of wave 3 and 1. Okay, I'll repeat it. Wave 2 is a vector addition of waves 3 and 1. Okay, so can you show me a P wave? Do you see a P wave here? No. Okay, we have a regular rate, but there's no P wave. Okay, this also has a characteristic sawtooth shape. Okay, this sawtooth shape tells us that this is an atrial flutter, and you can describe that further by telling, you can tell there are 2 P waves, three, before a QRS complex. So this is called a 3-to-1 conduction. So if you look here, you will see 2 P waves. The reason I do that is, if you know the pathophysiology of atrial flutter and fibrillation, you know there is an ectopic pacemaker that is also going to fire signals. Okay, you don't see one distinct P wave. Okay, this is a 2-to-1 block, 2 P waves and a QRS complex. Over here you have a 4-to-1 block. Okay, there's nothing difficult here. It's just about describing an atrial flutter wave. Okay, next we have atrial fibrillation, and this is called an irregular wave. Okay, these waves are going to be smaller than that of atrial flutter. You can see the distinct sawtooth pattern here, but in this you can't tell that. It's just something like this. This is due to several ectopic pacemakers. Okay, and one more thing I need you to know, if you look carefully, you will see that the rate is not constant. See, this is an irregular wave. Okay, there's around 4 boxes here. There's around 3. This is a bit more than 3. It's irregular. What does that mean? You can see that here. Okay, you can see that here. You can see the difference. Okay, and here are some causes of atrial fibrillation. Usually this is a common thing after myocardial infarction. Again, next we have ventricular flutter. In this condition, do you see a QRS complex? So till now, all the ECGs we saw had a QRS complex, but here we see no P complex, P wave, or a QRS complex. How do you know if it's a flutter or a fibrillation? First thing, the shape. It is regular, and it usually comes in a straight line. Okay, and just think about what happened here. Just take 2 seconds and think about what happened here. So basically what has happened here is they have removed the ECG LEDs. Okay, if you get situations like this, just don't panic. It just means the lead was removed. Okay, next we have atrial fibrillation, ventricular fibrillation, and this is a very dangerous condition. You can see the wave, because ventricular fibrillation can easily lead to sinus arrest. Okay, where you get the flat line. Look at this wave. It's going up and down. Okay, this is ventricular fibrillation. Okay, asystole is basically a flat line. So these spaces are for Prashant's notes. Next, we come to shape arrhythmias. Okay, I will give a final summary, but first I need to tell you, you need to look at each wave. Okay, you look at the P wave, you look at the the gap between the P wave and the QRS complex. Okay, you can see the gap here. Usually these should be very close to each other. I told you the rates before, check it out. But in AV block, there is going to be a conduction defect in which the conduction doesn't immediately go, it doesn't have the normal rate of conduction. Okay, so there is going to be a block between the atria and the ventricles. Now there's 3 types of blocks: first degree, second degree, and third degree. In the first degree block, you can see the PR interval is greater than 5 boxes. Okay, let me take the rhythm strip. Here you can see the gap. Okay, it's definitely greater, it's than 5 boxes, that is half of a big box. Okay, that is first degree AV block. Second degree AV block, the PR interval is greater than 5 boxes and it progressively becomes longer. Okay, it becomes longer. Let me find an ECG. Okay, usually I start off with the rhythm strip, so we'll go with that. If you look here, you can see here, look carefully, you will see that it is becoming longer. This is longer than this, and it has dropped a beat. Where is the beat here? There's no QRS complex. You get a P wave, but then there's no QRS complex. Okay, that's what you call dropping a beat. So in second degree AV block, Mobitz type 1, also known as Wernicke-Bach's, you get a PR interval greater than 5 boxes, becoming longer, suddenly dropping a beat. Okay, and this does not progress. Usually you get it after an inferior MI, does not progress, and so you do not need to really treat these patients. Okay, next, Mobitz type 2. In Mobitz type 2, we get a constant PR interval and then dropping a beat. So in type 1 heart block, there's no dropping a beat, but the gap is going to be greater than 5 boxes. In type 2, there's going to be a dropping of a beat. So type 2 Mobitz 1, the PR interval gradually increases. In type 2 Mobitz 2, the PR interval is constant, but you get dropping of a beat. Okay, look at this. You can see the gap. You can see the gap. There's no wave here. You can see these gaps are constant. Then there's no wave here. Okay, you can follow the wave and you can check it out. Next, we have heart block. Okay, and that also has a similar description as the atrial flutter wave. You talk about how many P waves are there to every QRS complex. Okay, so if you look here, what I need you to know about this is P waves are independent of the QRS complex. Atria contract independently of the ventricles. So this is called, this is third degree AV block. So this condition is called a complete heart block. Okay, so the atria and the ventricles have no communication. The atria contracts on its own, ventricles contract on its own. Okay, look at this. See the wave, the P wave is here, here, here. Actually, the easiest way is you find the gap. This gap is going to be constant, P, P, P. Then Q, Q. You can see a QRS complex. You can see the gap. The P waves are obviously independent of the QRS complex. Okay? And also, this situation, the waves may look funky because the P waves can be inside the QRS complex. Okay? Like in this example, you can see, okay, the P wave is somewhere inside the QRS complex. It's a vector addition, so you get a enlarged wave here. Okay. Next is the MI changes. So this is where the LEDs and their location is most important. Remember, if you see an ST elevation, so we have P, Q, R, S and T together, P, Q, R, S, T elevation, it is called ST elevated myocardial infarction or a STEMI. Okay. Basically, we are discussing the ECG changes seen in heart attack. If you look carefully, you can see the ST is elevated here. Okay, 2, 3, AVF. You can see the ST is elevated here. That is called an inferior STEMI. Okay, you look for this kind of wave. Okay, you can see in this ECG the lateral LEDs AVL, V5 and V6. You can see the ST elevation. You need to check each LED. You will see the second LED is normal, third LED normal, fourth fine, but here you can see you have to follow the wave PQRS complex. You can see the ST elevation. Remember, you need to always follow the wave. It can start off upside down, but just follow it. You can see it's a normal PQRS T. Each LED, each wave, just follow it. Okay, it's a strip. You just need to go on like this. Okay. Next we have, this is called a lateral STEMI. It's a lateral STEMI because you get the changes in AVL, V5, V6 mostly. Even V1, you can, in LED 1 you can see the change here. So you can see the P, Q, R, S, T elevation. Okay. Next, anteroseptal STEMI. 1, 2, 3, 4, 5, 6. So 1 to 4 is anteroseptal. Okay. You can see the ST elevation here. You can see P, Q, R, S, T. That's fine. But here you can see P, Q, R, ST elevation. ST elevation. Okay. Anteroseptal STEMI. These are a bit hard examples, but usually you get very obvious changes. Okay. And you get ST depression in the other LEDs which are not affected. Okay. What does that mean? So in this case, you can see 2 has an ST elevation, a ST depression. V3 has a ST depression. You can see P, Q, R, S, T depression. Okay, that indicates ischemic changes. Ischemic changes or ischemic damage to the heart during an MI. You see that in the other LEDs. Okay, not the affected LEDs, but the other LEDs, or just prior to a MI. Okay, so usually the doctors will look at that and tell, okay, this patient is highly likely to go into a STEMI within the next 20 minutes. They can tell that. So guys, let's start right bundle branch block. Okay. First, I want to tell you what happens in a bundle branch block. So we have our heart and we have the septa, then the right wall. Okay, I just want to highlight that area, so I'm just going to draw that. Okay, this is the right ventricles. So the impulse will come to the SA node and go along the bundle of His to the right bundle and the left bundle. This is the normal conduction pathway that I'm drawing. Okay, it will be going simultaneously so that the ventricles will contract at the same time. Okay, so what happens if there's a block here? If there's a block in the right bundle of His, the signal will go as normal to this side and the signal will stop here. So the ventricles will contract. The left ventricle will contract, right ventricle cannot. Next, what happens is the left ventricle will send the signal across the septum to the other side and contract the right ventricle. Okay, understand it? There's a block in the right bundle, so the conduction pathway will go to the left ventricle and that will contract, while the right side does not contract. Then the left ventricle will send its signal across the wall to the left ventricle will send its signal across the wall to the left ventricle, causing it to contract. Okay, left ventricle is activated normally, and where do we have the next definition? Yeah. Next, depolarization has to spread across the septum from the left ventricle. Okay? Now think carefully and tell me which LEDs will show right bundle branch block changes. Show that the right ventricle did not contract at the same time as the left. V1, V2, V3, V4, V5, V6. These are the precordial LEDs, the ones related to the heart. Okay? Once you keep around the heart. So V1 and V2 is on the right side of the heart. So you see the changes in those two. Okay? This is very important for right ventricular hypertrophy and for bundle branch block. So listen carefully. If you look carefully, you will see in V1 and V2, you will see that there is going to be one depolarization. The left ventricle has depolarized, and we have the second depolarization which occurs later, that is the right ventricle depolarization. So this shape which you get in V1, V2 is called rabbit ear. Okay? These are rabbit ear depolarizations because of the shape. Okay? And in the opposite LEDs, there's another change which you might see that is called a slurring S wave. Also in this, you get it in V5 and V6. The main thing you need to look for is the rabbit ears. If you see it in V1, V2, remember it's on the right side of the heart, so it's a right bundle branch block. Okay? And over here you see a slurring of the waves. Okay? You see it in V1, V2, V3. V2, V3 is more prominent. Okay? See? Slurred S wave. Okay, it goes down like this and comes up. Here are some reasons for right bundle branch block. This is basically right heart failure, pulmonary embolus, it's basically right heart diseases. Next, we have the opposite. Okay? So in this, I need to tell you, in V5 and V6, you might get W-shaped waves. Okay? So when you get, when it comes to bundle branch blocks, look for the rabbit ears. Okay? If you see it in V1, V2, right bundle branch block. If you see it in V5, V6, left bundle branch block. Okay? So in this situation, it's the same condition but reversed. We have the septa here, right ventricle, left ventricle, and now the block is on the left side. Okay, there's a block somewhere on the left side. while the right side will contract normally. Okay, there's going to be a block, so the conduction will stop here. So you need the conduction to pass from the right side of the heart to the left side of the heart. Okay, and remember V1, 2, 3, 4, 5, 6. So the changes you will get are in LEDs 5 and 6, the rabbit ears. Okay, V5 and V6. This is actually a very bad ECG. You don't see it properly, but basically you will see the same thing you saw in right bundle branch block here. Okay, and if you look carefully in the opposite lens, V1, V2, you will get W shaped waves. You can see that here. It's not very clear, but then it doesn't go sharp like this and come back. It comes, goes like this and comes. Okay, that is a W wave. So V6 for the M waves, V1 for the W waves. Opposite in right bundle branch block. In right bundle branch block, V1 for M waves, V6 for W waves. Okay, here are the shapes: V1 W waves, V6 M waves. Okay, and again this is related to the left heart diseases mainly. Okay, we will talk about hypertrophic changes, and what I want to discuss is ventricular hypertrophic changes. Okay, so I will not go into atrial hypertrophy much, but when it comes to ventricular hypertrophy, if there is going to be right ventricular hypertrophy, you will get a big R wave, P, Q, R wave, R, S, T, P, Q, R, S, T. In right ventricular hypertrophy, you get a big R wave in LEDs V1. Okay, I'll explain that. In LED V5, you get a big S wave. Okay, so it will look like this. Oh, sorry. Big R wave in LEDs V1, a big S wave in V5. Okay, I will explain this. It's all got to do with vector additions. So in left ventricular hypertrophy, we get the opposite. So we get a big S wave in LED V1 and a big R wave in V5, and the description is it's a huge wave. Usually it goes out of the ECG strip. Okay, now I will tell you why this happens. I need this image. Yeah, so if you take hypertrophy, it's all to do with vector additions. Okay, now you know V1, V2, V3, they're related to the right heart. V5, V6 is to the left heart. So when you have hypertrophy of the right heart, V1, V2 will have bigger changes. They will look bigger because the whole ECG, the conduction shifts towards this side, towards V1, V2. Okay, and this you will get a big dip in this wave. Okay, so this is in right ventricular hypertrophy. In left ventricular hypertrophy, you get the opposite, because the vector addition, because the waves are going to go more this way, there's going to be more waves traveling this way, you get a larger vector addition for V6, V5, V4 will also be a bit larger because the whole system shifts to the left side towards V5, V6. And in these you will get a dip in the S wave, an S wave dip. Okay, remember that, try to understand that. So we'll go back to the ECGs. Actually these ECGs are not that good, but basically in V5, V6 you get a dip. You can see this large dip, okay, in this wave. In V1, V2 you get a large wave, but in this is actually an ECG for atrial enlargements. Atrial enlargement might confuse you, that's why I'm not gonna do that. But you also get ventricular hypertrophy here. You can see the S wave dip in V6, and in this you can see the R wave rise and the S wave dip in V2. Okay, remember that, remember this. So that's it for the types of changes. Now we'll go over some different ECGs, different conditions and the relevant ECGs. First is a junctional tachycardia, also called as Wolff-Parkinson-White syndrome. Okay, what you need to look for is the delta wave, this wave which causes an angle like this. So usually it's supposed to go up like this and come down, but in this condition it goes up like this and comes down. Okay, you can see the slurred wave, slurred R wave. Okay, that is called the delta wave, and the treatment for this is procainamide. Okay, just remember that. Pulmonary embolism, in this condition we get these following ECG changes. S1, Q3 and T3 will have deep will have the changes. Okay, so S1, S wave in lead 1 will be deep. PQ R, S wave will be deep. Q3, deep Q wave in lead 3, sorry, it's here. You can see the deep Q wave. And also in lead 3 you will get inverted T waves. So instead of being like this, the same direction as the R wave, you will get an inverted T wave. Okay, remember this is a summary I'm doing. This lecture took more than 2 hours. Next we have the U waves, that is seen in hypokalemia. Now a U wave can be normal. If it is present, it might be normal, but if it is bigger than the T wave, here's the T wave, if it is taller than the T wave, PQRSTU, it is a condition of hypokalemia. Okay, this is hyperkalemia, and you need to look at lead V4. Okay, and you will see a peaked T wave. What does that mean? It's just the T wave, PQRS T wave, which is enlarged. You can see it has gone out of the ECG. Okay, PQRS T wave. Okay, actually look carefully. You will see that the R wave ends here and the T wave is going up afterwards. Okay, it's just the T wave which is peaked. Okay, next we have prolonged QRS segment, that is due to this drug called a TCA, which we give to treat psychiatric disorders. You get a prolonged QRS interval. Okay, these are things you need to know if you are planning to do USMLE. So next, pericarditis ECG changes. We have PR elevation and ST depression. Okay, now let's go back to the final review where I tell you exactly how to read ECGs. This is the main thing you need to take out of today's class. First, the 3 rules: rate, rhythm, and shape. First, you need to check the rhythm strip for the rate. Is it fast, is it slow, or is it normal? Okay, that's the first thing you look. You're checking the rhythm strip. Next, you check for the rhythm. Easiest one is always the rhythm strip. You check if a P wave is present. If it is not present, it is going to be either a flutter or a fibrillation. It could be ventricular or atrial origin. Okay? First, you check the rate, then the rhythm. Next, you must follow the shape. If both of those are normal, you follow the shape. What does that mean? You follow the ECG, use your fingers and just follow each wave. Okay? You need to follow each wave. So if there is any changes, let's say this wave is enlarged, the P wave, or it has a hump appearance, it is due to an atrial problem. Usually it's due to hypertrophy. Okay? Next, you look at this gap. This is the most important thing I need you to take out of this. Look at that gap. You check if it is large. If it looks larger than normal, larger than half of a big box, we say it's a hard block. Okay? The PQ gap tells you if there's a hard block. Okay? Next, the QRS complex. If you see a wide QRS complex with rabbit ears, that means it's a bundle branch block, or if it is tall, it is a hypertrophy. Okay? Next, you look at the next wave, S wave. Has the S wave elevated with the T wave? If yes, it is a STEMI. Has the S wave depressed with the T wave? If yes, it's ischemic changes. Okay? And you look at the T wave, and if you find it has elevated together with this, it is a condition in which, sorry, I forgot the condition, let me check. Hyperkalemia. Rare condition. You will not be asked in the 4th year to check those questions. And if you find a U wave, that could be a hypokalemia situation. This is all you need to know for ECG. Okay? So once you decide it's a bundle branch block, once you decide it's a hard block, just follow the rhythm strip, find what degree of block it is. Okay? Next, QRS abnormality. If it is a problem in V1, V2, it's a right heart problem, hypertrophy, or a bundle branch block. If it is abnormal, in the V5, V6, it's a left heart block or left ventricular hypertrophy. Okay, I have drawn this all here. And if there is ST abnormality, it could be elevated depression or in S1, Q3, T3. Okay. Next, T wave abnormality, U wave abnormality, done. If you can follow these rules, rate, rhythm, and shape, you can read any ECG. Okay, it's all about the practice.